And so you have different kinds of hazards with the drugs that you're using. That means that in the past, when a lot of oncology drugs, antineoplastics, drugs used to treat cancer, would have been added, you may see that a lot of oncology drugs either weren't added or they're added in a different place on the list than they were in the past. That has to do with some of the restructuring on the list we'll probably talk about later.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Jerry Ovesen, pharmacologist at the National Institute for Occupational Safety and Health, otherwise known as NIOSH, in the Centers for Disease Control and Prevention, about the latest update to the NIOSH list of hazardous drugs. Welcome and thanks so much for joining us today, Jerry.
Thank you so much for having me. I'm excited.
So to start things off, what exactly does NIOSH define as a hazardous drug, and why is this definition particularly relevant in the healthcare setting, especially in oncology?
NIOSH actually released a document in 2023 that's called the Procedures for Developing the NIOSH List of Hazardous Drugs in Healthcare Settings. And that explains the process NIOSH uses to evaluate the drugs. And part of that explanation is that it gives the definition that's laid out for how NIOSH defines a hazardous drug. The definition is kind of specific and kind of wordy, and I find that it's best to go over it kind of a chunk at a time. The definition starts with a drug has to be approved for use in humans by the FDA's Center for Drug Evaluation and Research, that's CDER, and it must not otherwise be regulated by the U.S. Nuclear Regulatory Commission, the NRC. And so this part of the definition lays out what kind of NIOSH is evaluating, what drugs and treatments NIOSH will look at. That's treatments that fall under FDA CDER, and it's not treatments that would fall under the FDA Center for Biological Evaluation and Research, so the CBER. Or it also doesn't evaluate radiopharmaceuticals. Then to meet the definition of a hazardous drug, so I proved to find what we'll evaluate, they need to be either accompanied by prescribing information in the package insert that includes manufacturer special handling information. So if the package insert has some information in it from the manufacturer that says it should be handled as a hazardous drug, then we take their word for it. Or it can be determined to be a carcinogenic hazard, a developmental hazard, a reproductive hazard, a genotoxic hazard, or another health hazard by exhibiting one of the following, and in this case, this is part of the definition, following toxicity criteria in human animal models or in vitro systems. And that's carcinogenicity, developmental toxicity, and developmental toxicity includes teratogenicity, reproductive toxicity, genotoxicity, organ toxicity at low doses. So if it has a specific organ toxicity at a low dose, or structure and toxicity profile that mimics existing drugs, determined to be hazardous by exhibiting any one of those 5 toxicity types. So to go over those 5 toxicity types, carcinogenicity is the ability to cause cancer. There's different mechanisms through which that can happen. Developmental toxicity is toxicity that causes damage to developing fetuses and unborn children. Reproductive toxicity is a toxicity that harms the ability to reproduce, so the ability to conceive children or to carry them to term. Genotoxicity is damaging to the DNA. This is often interrelated with carcinogenicity or developmental toxicity. And then organ toxicity kind of is a broader term that allows us to look at specific toxic endpoints that aren't in those 4 main ones, if they happen at particularly low doses. So if it's a very potent effect. And then structure and toxicity profile that mimics existing drugs determined to be hazardous. That allows us to look at drugs that maybe mimic the activity of a drug that's already on the list, but the data isn't there for it specifically yet. We try to look at every drug individually, every active pharmaceutical ingredient. We try to look at them individually, but this gives us a chance to look at some drugs that maybe all the data isn't available. That's the beginning part of how we define the hazard. But then we also have another criteria that we evaluate at the end of the definition, that is, if a drug also exhibits a molecular property that may limit the potential for an adverse health effect from exposure to the drug in the healthcare workers, it's determined not to be a hazard. And this is becoming more relevant as some newer mechanisms of action for hazards that can cause a hazard in potential drugs changes there's not a way for the worker to be exposed in a relevant way. The most common thing here is like a lot of the biologics are really large molecules and they can't actually get into the body sometimes. It's not always the case, and it has to be evaluated specifically for that API and the hazards that the API may cause. Like I said, specific and wordy.
As you said, as you pick apart each part of that definition, it kind of gives clues to what drugs we eventually will see. And some of those we'll talk about today, kind of how those, your guardrails for NIOSH are set up of like what exactly you're looking at even to begin with. So I do appreciate you kind of combing through that definition with such detail because it does essentially lead us to all the rest of the things that we'll talk about today. So moving on from that, can you explain how the definition that you've just given us of hazardous drugs, how does it sort of come into play when we're talking about common oncology treatments like oral anti-cancer medications or immunotherapies or other biologic agents?
As you pointed out, there's a lot there that you can kind of start to see how it interplays specifically with the oncology treatments. If you start at the very beginning of that definition, we only evaluate drugs approved by CDER and not drugs regulated by the Nuclear Regulatory Commission. That means some treatments used in oncology, like the radiopharmaceuticals, stand out because we never evaluate those. You'll never see a radiopharmaceutical on the NIOSH list. Another example that many people have noticed is BCG, Bacillus calamite urine, which is actually a live attenuated vaccine to TB. It's commonly used in the treatment of bladder cancer as an immunotherapy. It causes an immune response for the treatment of bladder cancer. But because it's a live vaccine, it is regulated and approved under FDA's Center for Biologic Evaluation and Research. And so it does not meet the NIOSH definition. And so it was recently, in this most recent update, removed from the list, not because its hazards any different than it was, but because it doesn't meet the NIOSH definition. Being a live vaccine, there is some small risk of infection. And the best practice is, of course, to treat it as a potential infectious hazard, probably. But it isn't approved by CDER, and so it doesn't officially meet the NIOSH definition of a hazardous drug. And the same with the radiopharmaceuticals. And then there's the list started in 2004. And at that time, the list was, in 2004, it was part of an alert. And in 2010, when the first standalone list came out, it was titled the NIOSH list of antineoplastics and other hazardous drugs. So it was kind of the oncology treatments were front and center then. And so especially in the past, many oncology treatments were genotoxic. And so at that time, a lot of the hazardous drugs were oncology treatments that caused this DNA damage. A lot of these get manufacturer special handling information. And so they get added to the list based on that pretty regularly. New drugs that are genotoxic can be added. But increasingly, the treatments for cancer don't rely on that mechanism. There's more nuanced and targeted ways to treat cancer now. And so you have different kinds of hazards with the drugs that you're using. That means that in the past, when a lot of oncology drugs, antineoplastics, drugs used to treat cancer would have been added, you may see that a lot of oncology drugs either weren't added or they're added in a different place on the list than they were in the past. That has to do with some of the restructuring of the list we'll probably talk about later. I often get a lot of questions about monoclonals because this is a common treatment used in oncology now. But people will ask, are all the monoclonal drugs safe to use because they're large molecules? Or they'll ask, are none of them safe to use because they're biologics? And some monoclonal antibody treatments could be immune, but each monoclonal is different. They come with a lot of potential hazards and a lot of different mechanisms of action. So you can have monoclonals that are immunotherapies, BiTE treatments come to mind there, but you can also have some that are conjugated to a small molecule that's very often a genotoxic molecule similar to those older styles of cancer drugs. And so those carry with them the same type of hazard that those previous genotoxic drugs would have carried. And so that's another example where it's kind of, you need to be specific. So everything will be specific for those drugs. And you can see how different types of drugs now are handled on the list differently.
We want it to be black and white, but it can't be. And as you mentioned, like historically, this stemmed from, at the time, what were exclusively anti-cancer drugs. And so this brought with it this sort of assumption that all drugs used to treat cancer are automatically hazardous. And as those drugs and treatments have developed, certainly different drug classes, different mechanisms of action. And so while I think it's still assumed, especially like if patients are coming to the infusion center to get their treatment, their monoclonal antibody for a non-cancer reason, there's just this assumption that every drug in the entire environment is hazardous. But we have to be, I think, clear about that because these drug classes are becoming so expansive and they're being used now for non-cancer indications. And so it really does us a disservice by not being clear about what type of drug is this. As you mentioned, is it attached to something? Is it pure drug or is it in combination with something? And then, of course, does that drug land on the list and where does it land? And so it's more complex than we wish it had to be, but it's important to understand the difference. So I am really excited to talk about it in more detail today with you here. So I know we've talked about this a little bit already, but I think it's worth kind of revisiting. What specific hazards do we see in these classifications on the NIOSH list? How do we classify drugs as hazardous?
We look through the data in the PI, the STSs, and other data that may be available to us. And we look for a carcinogenic hazard. So does this molecule, does this chemical, this drug, have the ability to increase the risk of cancer? A lot of the time that will also tie with genotoxic hazards, but not always. There are some drugs on the list that are carcinogenic through other mechanisms. Sometimes carcinogenicity can be related to hormone signals, can lead to increased risk of cancer. There's some nuance there, but is it a carcinogenic hazard? I can get it onto the list. Is it a developmental and reproductive hazard? Can it cause a risk to unborn developing fetuses? And can it cause harm to the ability to reproduce? Things such as teratogenicity, which is damage to the unborn fetus, or hazards that affect the ability to actually conceive an offspring. Or have they been shown to be embryo fetal? That is a concern a lot now. And then we look at genotoxic hazards. So can this molecule cause DNA damage? And usually that's a precursor to a carcinogenic hazard or developmental hazard, but not always. So it's important that we look at that and get a handle on that. And then we, as I mentioned earlier, we consider some specific other toxicities if they occur at very low doses.
Let's dive a little bit deeper. Just take a minute to talk about, as you already mentioned, some of the embryo fetal toxicity and some of the reproductive toxicity. Can we talk a little bit about the significance of that and what precautions healthcare workers need to take when they're dealing with these types of drugs? And they may be in some of those groups.
Those types of hazards, they don't stand out as right away. You might necessarily see them in a lot of workplaces. If someone's getting sick from some of the exposures at work, you can see them right away if someone's coughing or things. But things like embryo fetal, even carcinogenicity is not something that you notice right away. So like embryo fetal toxicity and reproductive hazards can cause damage either to the fetus or the ability to conceive. And it's important to take note if you have to handle these kind of drugs, particularly if you're pregnant or looking to become pregnant. But again, the precautions can differ depending on every facility based on the needs of your specific formulations and how you handle them. That's a really important part in the handling process when deciding how to handle them. It'll depend on what formulation of the drug you are handling. If you're handling it in a prefilled syringe or if you're handling it in a bag that's been filled in the pharmacy, that can change how you're handling it. So now I can't say what's right for every situation, but some organizations have suggested further precautions, such as temporary alternative duty for workers who are pregnant or looking to become pregnant. NIOSH can't say what's best for any given facility, but other organizations have given some good suggestions you may want to look into.
Absolutely. And ONS does have a position statement that talks explicitly about alternate duty and what is important to consider and whose responsibility is what in that whole area. I find that this category of hazardous drugs seems to be the one that always has the most surprising drugs for me on it. Again, because of just that specific type of embryo fetal, potentially even reproductive toxicity. But some of the drugs, and you mentioned this earlier, like hormonal therapies, like are not toxic in maybe it's sort of the classic way we consider other anti-cancer drugs, but they do carry that very specific type of toxicity if you were to be exposed to them accidentally. And so again, that category, I see some on there that I'm like, I would never have considered that drug to be hazardous in sort of this made up definition I have in my head. But when you look at the specific criteria that NIOSH uses, you can understand why these types of hormonal drugs and other agents would fall into that category.
That's a good point. And it's important to realize that the different drugs on the list, we don't really rank hazard. The list doesn't really rank hazard. I know a lot of people have kind of treated it that way a lot of times. We don't say that something is less hazardous if it's only a developmental or reproductive hazard, because if you're trying to have a child, then that's an important hazard to you. And we don't necessarily say something that's carcinogenic is more hazardous. And so a lot of people try to think of, when they're thinking about hazardous drugs, you're right. They do think about, those old school antineoplastic cancer treatments that are going to be genotoxic and cause my hair to fall out if I get exposed to them very highly for very long. Yeah, those are clearly hazardous, but people often forget about some of these other hazards. And I think that's important to pay attention to how things get on the list and the definition. It's really helpful for you to understand what's there and why.
Absolutely. And you mentioned if someone is actively pregnant or trying to conceive, like a big deal for them. But I think it's also just worth mentioning that you don't have to actively be trying to conceive to sometimes still conceive. And so
That's right.
the risks are there, whether it's your intention or not, it's a risk that's there. And so, even if it is an intentional desire to try to conceive, knowing those risks, if they're already there, then your body has been exposed to them for the months, potentially years leading up to this decision. And so again, it's important for everyone. I think I've heard in the past, nurses above a certain age were like, oh, well, I'm not worried about that. I'm not having any more kids. Well, it's still a risk. It's still a risk.
And again, sometimes it's easier for facilities to protect everyone and have a policy that protects everyone, just so you don't have to police that, right? This is not the kind of question you can ask your employees. Are you planning on? And even if you're not, again, to protect workers who again, not everyone knows when they are first pregnant or when that happens. And so, yeah, it's important to kind of protect everyone from that hazard. And it's often easier just to have a policy that protects everyone when you can.
So we've talked about this a little bit, but let's talk again, just reinforce the treatments that NIOSH does not evaluate for inclusion on the list. And then also kind of in that same question, how do we deal with the new therapies that have been and will continue to be approved since the list is published? It's sort of a stagnant document as soon as you put it out there. And so how do we deal with those drugs that come along after that list has been published?
So as we touched on before, the radiopharmaceuticals, which are regulated by the US NRC, the Nuclear Regulatory Council, we don't evaluate those. But I think for those, mostly people handle them as if they're radioactive materials. And so that leads to some protection. And then there's the drugs that are approved by the Center for Biologic Evaluation and Research. And those CBER drugs, a lot of people assume that's going to be all the biologics, but you'll notice that monoclonals have a biologic approval, but they don't go through CBER. The CBER really is those vaccines and blood products are the types of treatments that come through there. But some treatments that come through CBER that are becoming more important in oncology treatment are the gene therapies and cell-based therapies like CAR-T. So those modalities of treatment are increasingly important in oncology, but they won't be evaluated for inclusion on the list. Those are some that you might have to look at separately. Important in those is to look at what the manufacturer provides you. How does the manufacturer say to handle them? Does the manufacturer identify them as a potential hazard to workers? And pay close attention to that. Because again, for things like BCG, there's a low level risk of infection there, particularly if you're maybe immunocompromised. And so those are the kinds of things to look at there. I think the simplest way to understand the potential hazards of drugs that aren't yet evaluated by NIOSH is to start first with what the manufacturer has provided. Look in the prescribing information, particularly section 16 usually gives, that section's called how supplied, storage, and handling on most PIs. And that, particularly for the genotoxic drugs, which are common in oncology treatment, manufacturers will note that they are genotoxic, though they might call it cytotoxic in that section, and that they should be treated as a hazardous drug. Another good resource, if you're curious about a drug's potential hazards, can be the safety data sheets. Manufacturers provide facilities with safety data sheets, and so you can go looking for those. Your facility should have those somewhere. I think most people probably in their first few weeks, and then maybe once every year, every couple of years, gets training on where they can find the SDSs. But I don't know how many people actually go and check them out for the drugs that they handle.
That's great advice. As you said, those sheets, we get reminded of those sheets every year. We do our annual competencies of safety training, but do we ever look at them? I don't know. So that's a good reminder to consider some of those safety sheets just to make sure that we are up to date on what those recent drugs, what their structure is, how they work. And that might give us those clues of how we should be treating them in terms of hazardous potential.
Those SDSs often have hazard notations because there's a hazard communication requirement on those sheets. And so they'll have a hazard notation if the manufacturer suggests that they may have a potential hazard right there on the sheet. Often that's a helpful place to start.
So as you mentioned, NIOSH came out with a long-awaited, very excited to see update to the NIOSH list at the end of last year. How do these recent changes, how do you see them affecting oncology practices especially when it comes to making some of those decisions about handling, administration, and protective measures to use when using these medications?
The biggest thing that's causing a change for people handling the drugs and for people making policies about handling the drugs is the change in how the tables are defined and the structures of the tables. So before there were 3 tables on the list, and now there's only 2. Table 1, what's now Table 1 in the new list, is titled Drugs that have manufacturer special handling instructions in the package insert and or meet the NIOSH definition of a hazardous drug, and one or more of the following criteria are classified by the National Toxicology Program as a known to be a human carcinogen, or are classified by the International Agency on Researching Cancer as Group 1 carcinogenic to humans, or Group 2A probably carcinogenic to humans. So let's take a second to break that down because that table title is kind of big. But basically, if it's identified as a hazardous drug by the manufacturer using manufacturer special handling instructions, those drugs are added to Table 1. Then if it meets the NIOSH definition of a hazardous drug and it has been additionally identified by one of these 2 outside organizations, the National Toxicology Program or the International Agency for Research on Cancer, as a potential carcinogen, probable carcinogen, it gets added to Table 1. So Table 1 are your drugs that have the manufacturer special handling instructions, what we call MSHI in the document a lot, and drugs that are carcinogen. Then Table 2, the title of Table 2 is drugs that meet the NIOSH definition of hazardous drug and do not have MSHI or are not classified by the National Toxicology Program as known to be a human carcinogen and are not classified by International Agency on the Researching on Cancer as Group 1 carcinogenic to humans or Group 2A probably carcinogenic to humans. So basically everything that's not on Table 1. And some of these may also have adverse reproductive effects is added into that title to let you know that in addition to carcinogenicity and the other titles, some of these may have adverse developmental reproductive effects. That kind of changed to the tables, the shift from 3 tables to 2 tables and the definition of them has kind of changed where some drugs are on the list. And that has led to a change in the way some clinical environments, some facilities have had to set up their handling program. Because in the past, Table 1 was all the drugs that were used in the treatment of cancer. That table was, it met the NIOSH definition of a hazardous drug, and it happened to also be used in the treatment of cancer. It was an antineoplastic drug. That was Table 1. And in the past, that led a lot of facilities to just say, okay, these are the worst, so we will treat them with all the controls. And as the treatments for cancer changed in both their specificity and their mechanisms of action, those hazards changed. And it didn't make sense to kind of group them together that way anymore.
That makes sense. And again, we kind of started off with the big definition, and these clues were in there that were kind of giving us hints of how the structure was going to be changing based on that definition. And you make a great point of so many oncology drugs. Yes, they're used to treat cancer, but that mechanism of action kind of puts them in a different category or no category at all, potentially. So I think that's important to keep in mind. Do you have any examples or have you heard of how these changes in the table structure, how are they changing how oncology drugs are not only categorized, but handled by nurses in the clinical environment?
Some standard setting organizations have set standards for handling. Really, in the oncology setting, particularly oncology pharmacy setting, it's really changed how some of the handling happens there because some of the standards come out of the pharmacy world. And what's happened there is some drugs that are oncology drugs, they might have been on Table 1 before just because they were used in the treatment of cancer, right? They were antineoplastics, so they were on Table 1. Now, because they're not identified as a potential carcinogen and they don't have manufacturer special handling information, they are now on Table 2. And the standards, particularly for pharmacists from some of their organizations, have said that if you can justify certain steps of handling on these drugs that are on Table 2 at a lower potential type of handling. So let's say a monoclonal antibody that is a potential hazard and is used in the treatment of a cancer, but it's not a genotoxic, right? It has a different mechanism of action. It would have been on Table 1 before. And so in the pharmacy, at least, and also I think in most clinical settings, it would have been handled with pull gown, gloves, and maybe if someone's worried about splashing, a face mask or eye protection, right? Now that it's on table 2, if you can say, well, we handle this in such a way that there's no need to be wearing a full gown. We need to wear our double gloves still, and we're not worried about splashing of this monoclonal antibody when we're starting a line. And so maybe you can, in your handling protocol, lay that out and use a lower level of precaution, different PPE.
Listening to you respond, it brings up sort of an important distinction is that the NIOSH list, that's not the rules. That gives the information of how to make the decisions and how to set up those rules, as you said, policies and procedures. But, the NIOSH document itself isn't going to be the black and white rule. It's going to give you the information you need to either create or adjust the rules, which usually are in the form of policies. And so, what you've said and which makes sense now is that this new document is super helpful, but man, it probably blew up a lot of people's policies and procedures in terms of how they had things structured and categorized, and maybe had caused them to need to rework them.
Yeah, like I said earlier, the list doesn't now, and really it was never, truthfully, I think, intended to rather set certain hazards as more hazardous or more potent than any others, right? It just was an easy shorthand when we start setting up those policies. And so, yeah, for a lot of people's policies, the new table structures require some rethinking.
So how should these new classifications, the new table structures, what do you see the implications for as we move forward in oncology, new drugs, new chemotherapies potentially? How should these changes kind of impact how we handle these drugs going forward?
Like I said, that'll be up to individual facilities and standard setting agencies. I hope that the way that the tables are labeled now give people a little bit more information about what the hazard the drug is posing is, and lets them make decisions individually based on the drugs that they're handling. And then hopefully they also go and look at specifically at the formulations and the way they're handled in their facilities and determine what precautions are handled. For example, I mentioned that before there were 3 tables and now there's 2. And so there's some worry that there was a loss of information there. The 3rd table used to be just the drugs that were developmental or reproductive hazards. So those were kind of pulled out and set out separately into their own table. Now they're in with the other drugs, but we do still identify them. They'll be on table 2 because they're not carcinogens. They're only developmental or reproductive hazards. So they'll be on table 2, and we have a column that denotes this drug is only a developmental or reproductive hazard. So that information for those drugs is still there, but we make a point to say that they are only developmental and reproductive hazards. And so some of those other drugs, and I think maybe sometimes this information was lost on people, is that when they weren't on table 3, they didn't think of them as potential developmental or reproductive hazards. Drugs that are genotoxic can also be developmental or reproductive hazards. Drugs that are carcinogenic can also be developmental or reproductive hazards. So I think having the drugs laid out like this will allow people to look at the drug and think about each drug kind of as their own individual, as difficult as that can be for some policy setting situations.
And certainly our discussion today is focused on the hazards mainly to the healthcare provider who is handling the drug, administering the drug. But certainly for nurses, this trickles down to how we educate our patients and what precautions we share with them and how they need to kind of maintain, their own body fluids and things when they go home shortly after they get their medications. Now we know most cancers are treated with a combination of different drugs from across these different categories. And so ultimately you kind of have to teach to the most hazardous drug and give them those recommendations, even if they are getting perhaps an immunotherapy or a targeted therapy in the mix of all that. But again, those are things that I think as nurses, we want to make sure that once we understand how to protect ourselves, how does that information now influence how I teach my patient and what recommendations and cautions I give to them and their families when they go home after their treatment?
Yeah. And it's important to remember we are focused on oncology nurses here while we're talking, but the list is intended to think about all kind of healthcare settings. And increasingly, the home is a healthcare setting. There's a lot more home health that's happening, particularly around oncology treatment. And so a lot of the thought around the list is considering those places too. If you're, like you said, bodily fluids, when you go home, how long do you need to think about, is this patient excreting the drug or the drug byproduct? Is the patient's clothing or their bedding, is that potentially contaminated? What does the home health care nurse have to think about while they're there? And that's increasingly part of oncology care, it seems, the home health care.
That's a great point. As I kind of alluded to earlier, there's always a lot of anticipation when the hazardous drug list from NIOSH is going to be updated or what's going to change. Do you have any insights on, how regularly or when the next update might come? And how do we stay prepared for these types of updates?
I can't say now when the next update may come, when the next full update may be published. We have begun to work on that, and we're hoping to get to a more regular schedule after this recent lull due to updating the policies and the procedures and the other information available. One thing that's important to check occasionally is the webpage for the NIOSH hazardous drug list, where in healthcare settings 2024, where you would go to download the list document. Occasionally, if a drug comes out and has manufacturer special handling information, we'll go ahead and add it to the list. And since we won't add it into the publication, we typically have a table on that page that puts that there. If a drug is reevaluated and we find that the hazard is not as bad as expected, or it's not a hazard actually, and we can remove it from the list, sometimes we get new information and that happens. And so those kind of updates can be found on the webpage of the list. Now, this list has only been out since the end of December, and we haven't had a chance to add any of those updates to the page for the 2024 list yet, but that's where they'll be. And so that's a good place to go to check for updates of that kind of information.
Outstanding. And we will certainly include all of these important links in our episode notes for today's podcast as well. Well, Jerry, this has been a great conversation. Certainly something that oncology nurses deal with and think about pretty much every day of their job. So important information for them to be aware of, and certainly some great resources for them to check out and to stay up to date. As we get to the end of our episode, we like to always close things out with a short, kind of quick fire round of questions just to help summarize some of the great topics that we've covered today. So to start that off, what are some of the common misconceptions about hazardous drugs?
I don't know if it's a misconception. I personally think a lot about surfaces around where the drugs are handled and the outsides of drug containers. I think a lot of times healthcare workers think that they need to worry about the spills and if they actually get it on their hands. But I wonder how much people think about if they got it on their gloves and then the surface they touch with their gloves, and how contamination can move around and where contamination might be in the environment where they're working, not just can they be accidentally exposed directly from the bottle or the vial or the thing that they're handling.
What's something about this topic that's not often discussed, but you wish people knew more about?
We touched on it a little bit earlier. I really wish more people looked at their STSs. Every workplace has them, even for drugs, and most employees go through a training where they can find them. And I think more people should become familiar with them. I think that would be a huge help for people understanding the hazards of these materials, because if they oftentimes lay it out directly with a hazard notation. And so if you got good information on what's on an SDS and where you can find that hazard information, it'd be a great starting place for people to understand some of the hazards related to the drugs in their workplace.
We just touched on this, but just to reinforce, what are some additional resources, whether that's to help inform nurses and keep them up to date on their education, or for even patients or other providers who want to learn more about hazardous drugs?
Like I said, you can start with the list page where you can find updates to the page. But NIOSH also has a related document called Managing Exposures to Hazardous Drugs, Information for Healthcare Settings. And it provides some basic information for common handling scenarios in healthcare settings. And it's also available on our website. And I also know that ONS has recently updated the safe handling of hazardous drugs. And I haven't gotten a chance to look into the 4th edition yet myself, but I suggested the 3rd edition for a lot of people, even outside of oncology nursing, oncology care, to look at some of the information in there on handling, because there's good information in that on handling, like I mentioned earlier, the bed sheets and the linens, waste. There's lots of good hazardous drug handling information in that document. I think that's another good resource.
Wonderful. Well, Jerry, thank you again for joining us today. I think a lot of the information we covered today is not something that maybe the average nurse thinks about or knows. They know there's a list. They know NIOSH is out there, but thank you so much for spending the time to talk us through the process and the way that things are defined and decided at NIOSH. I think it's really been insightful. So do you have any final comments to share with our listeners today?
Yeah, I just want to thank you very much. Like you said, I think a lot of it, people know there's a list, but I don't think a lot of people know that how drugs get on that list and what being on the list means. So I was really excited to get this opportunity to share that information with your listeners and with you. Thanks.
Thanks so much. Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.